sensation because they are derived from the somatophysical layer and they are supplied by the somatic nerves and deviations. Similarly, the visceral layers, they aligns the outer surface of the viscera or the internal organs, and they are derived from the splanchnopuric layer of the lateral plate mesoderm, and they are supplied by the autonomic nerves so that it is insensitive pain and tactile and thermal sensation. And as we know, the function of the peritoneum, it provides the wet and smooth gliding surface and prevents the friction of the two layers and prevents the spread of infection by greater omentum, as we discussed before, that the greater omentum, it acts as a policeman or the police guard for the abdominal organs. And it provides the nutrition and innervation to the viscera and helps to retain the viscera in position, and it provides the surface for absorption. So they are the normal function of the peritoneum. So move on to the continuation of the yesterday's class. So the subdivision of the peritoneal cavity. So the peritoneal cavity is divided by the pelvic brim into the part within the lesser pelvis or within the pelvic cavity and the part in the abdomen proper. The part in the abdomen proper is further subdivided by the transverse colon and the transverse mesocolon. So here we can see the transverse colon and this one is the transverse mesocolon. So these two structures, it divides the total peritoneum into supracolic compartment and the infracolic compartment. As we know, the colon means the large intestine. So just above the transverse colon and the transverse mesocolon is the supracolic compartment, and below the transverse colon is the infracolic compartment. So here we can see the structures which are present in the supracolic, as we discussed yesterday. They are the liver, the stomach, the part of it, the first part of the duodenum. So supracolic compartment is this, which is occupied by the liver and stomach, and the infracolic compartment, the jejunum, ileum, and the pelvic organs are there. So this is the supracolic compartment, and this one is the infracolic compartment. So we have to consider to demarcate by the transverse colon and the transverse mesocolon for the supracolic and the infracolic compartment. So the supracolic compartment is subdivided by the liver into suprahepatic and subhepatic spaces. The space just above the liver and below the liver, they are the suprahepatic and subhepatic spaces. Both the suprahepatic and subhepatic spaces are collectively known as subphrenic space, since these spaces lie beneath the diaphragm. So subphrenic means just below the diaphragm, and subphrenic space we'll discuss later in separate class. Move on to the infracolic compartment. Just below the transverse colon and the transverse mesocolon is the infracolic compartment. Lies below the transverse mesocolon and behind the greater omentum. So below the transverse colon and behind the greater omentum. And root of the mesentery, it divides into two parts. So here we can see the attachment of the root of the mesentery, which is obliquely attached from the left side of L2 to the ileocecal junction like this. So it divides into two parts, the right infracolic compartment and the left infracolic compartment. So right infracolic compartment, this one, the triangular space, and the left one, which is open to the pelvic cavity. Are you getting? Do you have any queries? Priyanka, are you there?
Yes, ma'am.
Do you have any queries?
No, ma'am.
Dilasa, are you there?
Yes, ma'am.
Do you have any queries?
No, ma'am.
Okay. So move on to the right infracolic compartment. So here we can see the right infracolic compartment, which is the triangular and lies between the root of the mesentery, which is obliquely placed on the left side, and the ascending colon, okay, on the right side below the transverse mesocolon. So transverse colon and the transverse mesocolon. So this is the triangular space which is bounded by the ascending colon, transverse colon, and the root of the mesentery. So this is the right infracolic compartment, and triangular with the apex directed below. So here we can easily appreciate the apex which is directed below, and The space is closed so that the infection from the pelvis rarely affect the right compartment because of the total boundary, because of the boundary by the ascending colon, transverse colon, and the transverse mesocolon, and the root of the mesentery, which forms the complete boundary of the right infracolic compartment. So this area is rarely affected by the pelvic organ. So this is the right infracolic compartment, and move on to the left infracolic compartment. So this one is the left infracolic compartment. It lies between the descending colon on the left side. Okay, so this is the descending colon on the left side and the root of the mesentery on the right side and below the transverse colon. So here we can easily appreciate that this left infracolic compartment is open to the pelvic cavity, so that if there is any infection in the pelvic cavity, it can affect the left infracolic compartment. So the boundary of the left infracolic compartment is the root of mesentery, the transverse colon and transverse mesocolon, and the descending colon. So that here we can easily appreciate the communication between the left infracolic compartment and the pelvic cavity. So if there is any infection in the pelvic cavity, can easily communicate the left infracolic compartment. Move on to the paracolic gutter. Yesterday we discussed about the space on each side of the ascending and descending colon. They are the paracolic gutters. So this is the right paracolic gutter and this is the left paracolic gutter. So the right and the left paracolic gutter form a longitudinal channels along the lateral side of the ascending and the descending colon respectively. So right paracolic gutter on the lateral aspect on side of the ascending colon, and this is the left paracolic gutter on the side of the descending colon. Both the channels freely communicate with the pelvic cavity across the pelvic rim, so that if there is any infection in that area, it can communicate to the above and below and vice versa. So right and the left paracolic gutters are there. So the right paracolic gutter communicate above with the hepatorenal pouch of motion. See, it is one of the some friends discuss in detail about it in later classes, but the right paracolic gutter, here we can see the communication between the right paracolic gutter, the pelvic cavity, and the hepatorenal pouch of Mauritian. So if there is any infection in the supracolic compartment, it can communicate to the pelvic cavity, and similarly, if there is any infection in the pelvic cavity, it can easily communicate to the hepatorenal pouch of the Mauritian. So the pus can drag down in the any other area, and through this gutter, the infected fluid may extend downward from the hepatorenal pouch or from the lesser sac, or the infection may extend upward from the appendix. So the infection from the appendix can go to the hepatorenal pouch of Mauritian, and the infection from the stomach and in this area can easily communicate to the pelvic cavity, so that it provides the passage or the channels for the transmission of the infection. The gastric content may be found in the pelvis along this gutter following the perforated gastric or the duodenal ulcer. So if there is any perforation of the duodenal ulcer or the gastric ulcer, the pus can drag down via this route to the pelvic cavity. Or the infection from the appendix, it can communicate to the above area, the supracolic compartment area. And the left paracolic gutter is, however, separated in the upper part from the spleen by the phrenicocholic ligament. So the phrenicocholic ligament is the ligament which is attached to the descending, the junction between the transverse colon and the descending colon and to the spleen. So this makes the lack of communication of the left paracolic gutter, left paracolic gutter to the supracolic compartment. So the infection will be limited only here because of the attachment of the phrenicocholic ligament here. So move on to the disposition of the peritoneum. So the greater sac extends from the diaphragm to the pelvic floor and can be well appreciated by tracing the peritoneum in the vertical and horizontal disposition. So vertical disposition is a single topic, whereas the horizontal disposition can be studied in different level below the transverse colon, between the epiploic foramen and the transverse colon, opposite the epiploic foramen and above the epiploic foramen. So the horizontal disposition we will discuss in other class. So move on to the vertical disposition. So do you have any queries till now? Roshan, are you there?
Yes, ma'am.
So do you have any queries?
No, ma'am.
No? Are you getting?
Yes, ma'am.
Okay. Charisma,
Yes, ma'am.
are you getting?
Yes, ma'am.
Or do you have any queries?
No, ma'am.
Okay. So move on to the vertical disposition. So here we can see the reflection of the peritoneum in the different viscera. So this is the liver, the stomach, the transverse colon. You can see the pancreas here in the posterior abdominal wall. This is the mesentery, and this one is the small intestine. So the peritoneum, they are reflected from above downward, is known as vertical disposition. So since we discussed yesterday about the ligaments of the liver, so the anterior abdominal wall, there is the attachment of the falciform ligament from the anterior abdominal wall to the anterior surface of the liver. So here. And the right layer of the falciform ligament, it continues as the superior layer of the coronary ligament, and the left layer continues as the left triangular ligament. So the vertical disposition starts from here. So this is the left triangular ligament, and this one is the superior layer of the coronary ligament on the anterior and the posterior, anterior and the superior surface of the liver. So here we can see the bare area which is bounded by the superior layer and the inferior layer of the coronary ligament. So we are tracing the falciform ligament on the left side and the right side. So the right layer, it covers the diaphragm to the upper surface of the right lobe of the liver as a superior layer of the coronary ligament here. This is the superior layer of the coronary ligament. Then it covers the anterior surface, inferior border, and the inferior surface of the right lobe of the liver, this lobe, inferior border. And tracing further, it covers the gallbladder here and reflected to the upper part of the right kidney. So here we can see the impression of the right kidney on the visceral surface of the liver. Then it forms the inferior layer of the coronary ligament, that is the hepatorenal ligament. So this is the inferior layer of the coronary ligament, that is the hepatorenal ligament. So you have to think from the anterior aspect. The peritoneum is covering the anterior surface, and then inferior border and the visceral surface, and then it reflects here by forming the inferior layer of the coronary ligament or the posterior layer of the coronary ligament. Then on the right side, it forms the right triangular ligament. So this one is the right triangular ligament, which is formed by the union of the superior layer and the inferior layer of the coronary ligament. So this is the right triangular ligament. The inferior layer of the coronary ligament on the left side reflects to the groove for the inferior vena cava. So this is the groove for the inferior vena cava, and the caudate lobe of the liver then continues as the lesser sac. So this is the lesser sac. And the base area of the liver is the triangular space between the superior and the inferior layer of the coronary ligament in the posterior surface of the right lobe of the liver. So this is the superior layer of the coronary ligament, which is formed by the right layer of the falciform ligament, and this is the inferior layer of the coronary ligament, which is formed by the reflection of it. Then the inferior layer continues below and covers the part of the right kidney and the second part of the duodenum, and it forms the hepatorenal pouch of Morrison, which is the space between the liver and the kidney on the right side. So this is the right triangular ligament. And inferior layer, it reflects on the upper surface of the kidney. Do you have any queries? Anybody? Do you have any queries? Sonali, are you there?
Yes, ma'am.
Do you have any queries? Anybody?
No, ma'am.
Okay. Denise, are you there? Denise, do you have any queries? So the reflection of the inferior layer of the coronal ligament, it reflects on the upper surface of the suprarenal gland and the kidney of the right side, and it forms the hepatorenal pouch of Mauritian. Then it covers the front and side of the ascending colon and the cecum, forming the right paracolic gland gutter, as I discussed right now. Further tracing, it enters to the pelvic peritoneal cavity after passing over the right pelvic brim, and the rest of the peritoneum covers the inferior surface of the liver, gallbladder, chordate lobe, fissure for the ligamentum teres, left wall of the fissure for the ligamentum venosum, and continues as the anterior layer of the lesser omentum, and that attached to the porta hepatis. So here we can see the porta hepatis. So anterior and the posterior layer of the reflecting peritoneum at the free margin of the porta hepatis. So this is the free margin of the porta hepatis. The anterior and the posterior layer of the lesser omentum are continuous. So this is the free margin of the porta hepatis. Okay. So the reflecting peritoneum from here to here, it goes like this. It reflects and it goes like this and it forms like this. Okay. So this is the reflection of the peritoneum on the liver. The anterior layer of the lesser omentum. Okay. So here, this is the anterior layer and the posterior layer. Anterior layer and the posterior layer continues in the porta hepatis. So this layer, the anterior layer of the lesser omentum, covers the anterior-superior surface of the stomach. This. So anterior-superior surface of the stomach, and continues below as the greater omentum. So here we can see the greater omentum. Okay. And as we discussed yesterday, the greater omentum, it has the 4 layers, 1, 2, and 3, 4. So 1 continues as the 4th layer and 2 continues as the 3rd layer. So this is the fold which are forming the greater omentum. Here we can see the bluish one, greater omentum. Then it reflects and reaches to the anterior superior surface of the transverse column. So if it reflects like this and it reaches to the transverse column, it reflects to the anterior border of the body of the pancreas. So here we can see this is the body of the pancreas. So it reflects by forming the anterior covering of the transverse colon, and it reaches to the body of the pancreas. So the transverse mesocolon attached to the transverse colon and the anterior border of the body of the pancreas here. Then it reflects and includes the transverse colon, and finally it forms the mesentery. It reflects it downwards and it forms the mesentery, and it includes the jejunum and the ileum. So the reflection of the peritoneum from here, it includes all the structure of the liver and then the stomach, and it forms the greater omentum. It reflects back and it covers the transverse colon and anterior surface of the pancreas, and then it reflects downward and it covers the small intestine by forming the mesentery. So that is the main reflection of the peritoneum in the abdomen. In the pelvic cavity, as it goes down in the pelvic cavity, it includes the sigmoid colon by the sigmoid mesocolon. So this is the sigmoid colon, which is enclosed by the sigmoid mesocolon we discussed yesterday, and the rectovesical fold, the fold between the rectum and the urinary bladder is the rectovesical fold, and then it forms the median, medial, and the lateral umbilical ligament or the fold, and finally merge with the parietal peritoneum of the anterior abdominal wall, and it completes the gaiter sac. In case of female, there is the uterus. Okay, so this is the uterus, and there is uterovesical pouch, the reflection of the peritoneum between the uterus and the urinary bladder, recto-uterine pouch between the rectum and the uterus, and the broad ligament of the uterus on each side of the uterus. Okay, So these are the other ligament which are only present in case of female. Other structure or the other fold of the peritoneum which are can be seen, can be found only in case in the female. So the pelvic line of reflection of the peritoneum. So this is sigmoid colon, and this is uterus. On each side there is the broad ligament of the uterus. That is also the fold of the peritoneum, and this is the vagina. So here in case of male, we got the reflection of the peritoneum from the anterior aspect of the upper part of the rectum to the urinary bladder. So this is the rectovesical pouch in case of male. So here we can see the sigmoid colon and the rectum. So the reflection of peritoneum only in the upper part of the rectum anteriorly, and then it reflects to the upper surface of the urinary bladder, and it goes to the anterior abdominal wall to complete the greater omentum. So this is the rectovesical pouch in case of male, and these are the other structures of the male. So urinary bladder, prostate, the seminal vesicle, ejaculatory duct. So they all are covered just above by from the reflection of the peritoneum by the here from the rectum to the urinary bladder. In case of female, the uterovesical pouch, so reflection of the peritoneum from the uterus to the urinary bladder. So this is the uterovesical pouch, the blue lining, and the rectouterine pouch, the reflection of the peritoneum from rectum, upper part of the rectum to the uterus. So rectouterine pouch is also known as rectouterine pouch of Douglas, and it is one of the very important area where there is the collection of the pus during any other infection or peritoneal infection, because this is the dependent part when the individual is in supine and standing position. And another one is the broad ligament of the uterus, as I have seen, I show you just before. So these are the structures only present in the female. So rectouterine pouch and uterovesical pouch. Vesicle means urinary bladder. Okay, so rectouterine and the rectovesical pouch. So rectouterine pouch of Douglas is the area where there is the collection of the pus during peritonitis. And it reflects to the anterior abdominal wall. It forms the median, medial, and the lateral umbilical fold to complete the greater omentum. So this is the median umbilical fold in the anterior abdominal wall in the pelvic cavity, and this is the medial umbilical fold, and this one is the lateral umbilical fold towards the inferior epigastric vessels. So median, medial, and the lateral umbilical folds are there. So these folds are responsible to complete the peritoneum on the anterior abdominal wall, and it completes the formation of the greater sac. We can see these structures during the dissection of the pelvic. So that's all about the vertical disposition, and we'll discuss about the horizontal disposition in the next class. So move on to the clinical anatomy. So do you have any queries till now? Janisha, are you there?
Yes, ma'am.
Janisha, do you have any queries?
No, ma'am.
Are you getting? So you have to follow the reflection of the peritoneum from the initial stage from the falciparum ligament attached to the anterior abdominal wall and the liver to the complete formation of the greater sac to the anterior abdominal wall by forming the median, medial, and the lateral umbilical ligament. Okay, so in between we have to see the intraperitoneal structure and the retroperitoneal structure so that we can easily follow the reflection of the peritoneum. And the horizontal disposition we will discuss later. Okay.
Yes, ma'am.
Okay. Yuvraj, are you there? Yuvraj,
Ma'am. Yes, ma'am.
are you getting the peritoneum?
Yes, ma'am.
Do you have any queries till now?
No, ma'am.
Okay. So we'll move on to the clinical anatomy or the applied aspect. Okay. So the peritoneal infection, many times we heard about the peritonitis, that is the infection of the peritoneum, and the infection may gain entrance to the peritoneal cavity through the several routes, as we discussed before, the communication in the different compartment, and there may be the open communication in the female from the uterine ostia. Okay, so these all are the roots of the infection in the peritonitis to cause the peritonitis. Through the anterior abdominal wall, there may be the infection from the anterior abdominal wall by the uterine tubes in the female, by the ovarian ostia, which are present in the fallopian tube. And it may be the infection from the blood by the bacteremia, from the interior of the gastrointestinal tract, from the duodenum, from the stomach. There may be the peptic ulcer, duodenal ulcer, perforation may be there, and there may be the gallbladder. The gallbladder may be enlarged, may be perforated, may be infection over there. It can, in any area in the abdominal structure, it can communicate to the peritoneum and leading to the infection or the inflammation of the peritoneum, that is known as peritonitis. Okay. And another term is the paracentesis, the surgical puncture of the peritoneal cavity for the aspiration or drainage of the fluid is called paracentesis. You can easily see in the hospital in the GI section, because there may be the ascites patient and the fluid is tapping from by the procedure that is known as paracentesis. So this is the surgical procedure, surgical puncture of the peritoneal cavity for the aspiration or the drainage of the fluid. And in the ascites patient looks like this. Okay, because of the more amount of the fluid in the peritoneal cavity, the abdomen becomes swollen. It looks like swollen. Okay, so ascites is the collection of excess fluid, more than 50 ml, more than normal quantity of the fluid in the peritoneal cavity is the ascites. So in these ascites case, we have to do the paracentesis to aspirate the excess amount of the fluid. And the collection of the fluid or pus in the dependent area, as I discussed before, in case of female, the rectouterine pouch of Douglas is the dependent area, and the hepatorenal pouch of Morrison is the dependent area. So these are the area where there is the collection of the pus or the fluid in case of peritonitis. And we discussed that the greater omentum, it acts as an abdominal policeman, and it helps to localize the infection. So it wraps around the infected area and it helps to localize the infection so that the spread of the infection will be prevented. And if it undergoes torsion, then the blood is cut after that it undergoes the necrosis. So if there is any torsion or the round up of the peritoneal fold, the greater omentum, sometimes the blood supply to the other area will be hampered, and this area can goes to the necrosis because of the lack of the arterial supply. So that is the main function of the greater omentum. It acts like a policeman. It helps to localize the infection. It helps to prevent the infection in the abdominal cavity. In the perforated peptic ulcer affecting the posterior wall, the gastric content escapes in the omental bursa and it can seize the epiploic foramen, and it may communicate the paracolic ulcer on the right side and can goes to the infection in the pelvic cavity also. And occasionally a loop of the intestine passes through the foramen of Winslow, okay, and into the lesser sac and becomes strangulated by the edge of the foramen. So that is the internal herniation can occur in the foramen of Winslow. And the next very important is sometimes the cleansing fluid is circulated through a tube inside the peritoneal cavity to absorb the waste product and to discard it. So this is the method of peritoneal dialysis. The bag containing the dialysis solution and the tube is connected to the peritoneum so that it can help to remove the toxins and the excess fluid. So this peritoneal dialysis is done to remove the excess fluid to remove the toxins, for example, collection of the urea in kidney failure patient. So the peritoneal dialysis will help to remove the toxins and the excess fluid. So that is the peritoneal dialysis. So these all are the very important applied aspect of the peritoneum. So do you have any queries from yesterday's class and today's class? Anybody? Aryan, are you there? Dheeraj, are you there?
Yes, ma'am.
So do you have any queries?
No.
Okay. So read about the yesterday's class, the terminologies and the different folds, and read about the vertical disposition and applied aspect. And we'll continue the horizontal disposition and subphrenic space in the coming classes. Okay. So that's all for today. Have a good day.